Hello everybody. Today we are going to undertake interpretation of an ECG recording of a 36 years old patient and should try to understand what the graph represents. Thus here is the graph. We shall compare both the normal standard graph and the graph under question. The normal graph, as evident, is presenting the points for comparison and confirmation how it is different in the given graph. Now, firstly, we shall take a review of the normal ECG graph. This normal pattern represents the graph occurring during one cardiac cycle, and it includes the P wave, Q wave, R, S, T wave, along with the measurement of PR interval, PR segment, QRS interval, ST interval, ST segment, and likewise. Now, it should be kept into view for the purpose to compare the difference which is occurring in the given graph of that patient. And now if we observe the graph of the patient, here we will find that the graph is something different. For example, this lead 1 is inverted, and likewise other changes also here present. Graph has summarized its observation in two ways. Number one, it has given some measurements like this one, AR 118 BPM. AR represents arterial rate, that is 118 beat per minute. VR, ventricular rate, it is also 118 beat per minute. Next, the QRST, this is QRS distance, that is 110 millisecond. Now QT interval, it is 334 millisecond. The QTC is 468 millisecond. PR interval 160 millisecond, and PRT means the axis deviation that represents the 136 degree and 22 degree. And again here it summarizes what is abnormal in this graph, and that abnormality is represented here as sinus tachycardia, incomplete right bundle branch block, right axis deviation, ST elevation in anteroseptal leads, ST elevation in V1, V2, suggestive of Brugada pattern. Here it is also suggested to rule out the acute coronary syndrome. No progressive change seen in comparison with the previous ECG done at 12 and past 11 minutes. It means these all observations are precisely given by this graph, and now we have to interpret. For example, this the AR arterial rate 118 beat per minute, VR ventricular rate 118 beat per minute. Now It is normal. It is the normal pattern of heart to beat at the same rate in the same pattern under influence of the same pacemaker. Now there are certain conditions where you will find the atria and ventricle both beats independently. For example, in the case of third degree block, where the AB dissociation takes place and atria beats under influence of the sinus activity, sinus pacemaker, and that is normal 80, while the ventricle beats under influence of the ventricular pacemaker, that is 40. And likewise here I want to say that there must be certain difference, so AR and VR has been quoted here. Now the QRSD, this is the distance of this QRS pattern, QRS complex. This QRS complex, if we undertake here in its normal condition, so normally QRS complex ranges from the 0.8 or you may say 80 to 100 millisecond, while here it is 110 millisecond. It means it is different, it is abnormal. The first we considered the arterial and ventricular rate, that is 118 per minute. It is also abnormal. It represents here, which is given in the abnormal observation, that is sinus tachycardia. Tachycardia represents the heart rate more than 100 per minute, and here it is 118. That's why this sinus tachycardia we must be considered or confirmed. Now one thing I would like to remind here, that you know how to estimate the heart rate by observing the graph, and it is, I think, certainly in your conception that the heart rate is estimated using the 1500 method, where the one R wave and second two consecutive R wave, which difference they produce in their occurring. Suppose here the two R wave are at distance of near about 12 small squares and slightly more. Now if we sum up the condition on the basis of 1500 method, we will find that if 1500 is divided by 12.2 and something, you will find the 118 beat per minute, and this represents the tachycardia. And in this way you estimate the heart rate by considering the consecutive two R waves. Again, QT interval is 334 millisecond, and we know that normal QTC is between 350 to 440 millisecond. Now this QT or QTC requires a little bit description. We know that QT interval represents the total time taken for both depolarization and repolarization of the ventricle, measuring from the onset of Q wave to the end of T wave, ranging from 350 to 450 milliseconds in male and a slight longer, that is near about 360 to 460 milliseconds in female, but it normally varies according to the age, sex, and especially the heart rate. In regard to heart rate, its relation is inversely proportional. How far QTC is concerned, it means corrected QT interval. C represents for corrected. Corrected QT interval, and it estimates the QT interval at the standard heart rate of 60 beat PM, means to say the QT interval when heart rate is 60 beat per minute. At this level, QTC becomes equal to QT interval. It is estimated following different formula. The most common among them is Bajet's formula, composes as QTC is equal to QT interval divided by root under RR interval. Here you can confirm the extension of QT interval right from this origin of Q wave and up to the summit of this T wave. This much extension represents the QT interval, which we have already discussed, that it measures 350 to 450 milliseconds. Now, the next observation which has been given in the result, that is the right axis deviation. It is well known to we all that right axis deviation is estimated by observing two leads. Number one, this lead 1, it is inverted lead 1 and upright AVF. You can visualize it more clearly. This lead 1 is inverted and AVF is upright. This type of the graph represents right axis deviation. Next to it, here is an observation regarding the ST segment, that is ST elevation. ST elevation in anteroseptal leads. I think there is no any confusion regarding the anteroseptal. Anteroseptal means anterior and septal. The lead received or collected by connecting the electrodes on the anterior aspect of the heart as well as the septal region, and these are represented by 4 chest leads, V1, V2, V3 and V4, where V1 and V2 are the septal lead, while the V3 and V4 are the anterior leads. Here, in this case, ST segment is elevated in V1 and V2. You may say here in V1 and V2, ST segment is elevated, and this elevation of ST segment at the V1 and V2, it represents Brugada syndrome. Brugada's pattern is accompanied with certain other features. It confirms the syndrome. Brugada syndrome is a disorder characterized by sudden death associated with one of the several ECG patterns characterized by incomplete right bundle branch block and ST segment elevation in the anterior precordial leads. Here it means the elevation of ST segment in V1 and V2 along with the other features confirming the partial incomplete right bundle branch block. The bundle branch block may be very clearly understood by observing this one. Here you may see this is SA node, here is AV node. Now from AV node bundle of His starts and reaches up to the upper fibrous portion of the interventricular septum, and where there is junction of fibrous and muscular part, this total bundle of His divides in two branches, the right bundle branch and left bundle branch. If the impulse proceeds from here and reaches up to this level, and the etiology which has already been stated here, under effect of that the right bundle branch blockage occurs. It means the impulse is not passing through this right bundle branch. This right bundle branch tends to occur following different etiologies like right ventricular hypertrophy, atrial septal defect, WPW syndrome, myocarditis, cardiac contusion, right ventricular strain due to acute pulmonary embolism, idiopathic. Likewise, almost these are the conditions under which the right bundle branch tends to occur. Now here, how far it is concerned with this syndrome, it is though rare, but when it occurs, it terminates into life-threatening condition. Again, in the most cases, it remains asymptomatic. But if the symptoms occurs, it most frequently includes the dizziness, fainting, labored respiration, irregular heartbeat or palpitation, extremely fast and chaotic heart rate, seizures, and those ECG findings which confirm it, that is the elevation of ST segment in V1 and V2 along with this right bundle branch block. This syndrome most frequently occurs in the persons with structural defect in its heart. And again, it is most frequently found in the Asians and especially in males. If it occurs, certain risk factors like this must be considered. And now, if it tends to develop, it may produce certain complications like sudden cardiac arrest or fainting. Again, following further description of this syndrome, we will find that it appears or it has been divided into or classified into three types. Like type 1, it is represented by the feature that lead V1 has a curved ST segment elevation of at least 2 mm followed by a negative T wave. It represents the type 1, and the type 2, under which there is a saddleback like appearance of the ST segment in lead 1 with ST segment elevation of at least 2 mm in lead 2. This may be present in normal individual also. And again, the type 3, the features of type 1 plus features of type 2 along with the height less than 2 mm of the ST segment elevation describe this type 3. Now, at last, following the suggestion given in the graphic recording to rule out the acute coronary syndrome. Here, we have to review once again the characteristic and features of this acute coronary syndrome so that it can be differentiated from this present case, that either it is present anyhow here or not. For this purpose, we must review that it is the term that encompasses both unstable angina and myocardial infarction. Again, it may present as a new phenomena or against a background of chronic stable angina. The lesion is usually a complex, ulcerated or fissured atheromatous plug with adherent platelet-rich thrombus and local coronary artery spasm. If this condition is recalled, we must compare the clinical features and the features of prolonged cardiac pain involving the chest, throat, arm, epigastrium, back, etc., or anxiety and fear of impending death, which is very crucial and important, nausea and vomiting, breathlessness, collapse or syncope. These symptoms allied with certain signs of the sympathetic activation like pallor, sweating, tachycardia, or sign of vagal stimulation like bradycardia or vomiting. Again, sign of impaired myocardial function like hypotension, oliguria, cold perspiration, narrow pulse pressure, raised JVP, third heart sound audible, which is not usually audible under the normal condition, quick first heart sound, diffuse apical impulse, lung crepitation, sign of tissue damage like fever, or sign of complication like mitral regurgitation. These are the features which confirm the presence of the acute coronary syndrome, and if any of these features or a collection of these features present in this condition, you may say that it is hindering the condition. But as I think this is not present here, so this may be ruled out. In this way, we became able to describe this graphic recording of ECG, and I think this would be the proper way to understand each and every ECG for the purpose of its better understanding. Now, with these words, I would like to put an end to this episode, and we shall again meet with some further other description. Thank you.